Thank you to all of the attendees who have logged in so far. It's a pleasure to have you here. My name is Sebastian Karlström, and I'm the Communications Manager for LifeClean International. And first of all, I want to give you all a sincere thank you on behalf of the entire team LifeClean. We have received a lot of feedback on today's seminar, and we share your excitement about it. And I should say that this is the first time that we are utilizing this webinar technology from Zoom. So please bear with us if a technical glitch would occur, but we're all friendly people here, so that won't be a problem. And today's event is part of LifeClean's relaunched Academy initiative. And that begs the question, what is LifeClean Academy? And we at LifeClean, we have been talking for years about the really dire need to combat dangerous microbial agents. And I think after COVID, it has been made painfully clear to all of us that we need to work together to raise awareness about important topics regarding cleaning, disinfection, and infection prevention and control. And speaking as a representative of LifeClean, who is a research-based company, we have come to the conclusion that we need to do more to combat these threats. And we strive to be the solution in disinfection, and therefore also in infection prevention. And to be the solution, we need to do more. We need to do our part in raising awareness and to educate our stakeholders. And that is what the Academy Initiative is all about. And today's topic, biofilm, is, as you will see, a very important topic. And I'm slightly embarrassed to admit that I certainly wasn't aware of the severity of the issue. So I hope that today's lecture will be an eye-opener for you guys in the same way as it was to me. We're very proud to have Phil Bowler here joining us today. He's a genuine expert on the subject. Phil has over 30 years experience in the medtech industry, primarily in wound care, infection control, and in medical devices. He's recognized as an expert in the field of wound care science and innovation, and he has published over 100 articles in medical and in scientific journals. And if you got any questions to Phil, please utilize the Q&A function. We will try to cover some of these after the presentation. And also please note that this seminar is being recorded and that the recording will be made available in the near future. So in order to not break the schedule, I will give the floor to Mr. Phil Bowler. Thank you.
Thanks very much for the introduction, Sebastian, and hello to everybody around the world, whether it's morning, afternoon, or evening. It is my privilege to be involved in this session hosted by LifeClean today. I want to thank the LifeClean team for inviting me to present on this topic, which is of great importance to me. It's of great importance globally about controlling healthcare associated infections as best possible, because as the slides will show, this is a huge global problem and we need to do our best to control it as effectively as we can. But as Sebastian indicated, I'll be talking about one particular aspect of infection control, and that is biofilm, that's largely overlooked. It's widely overlooked, whether it's be in healthcare or amongst the public. This thing called biofilm is largely it's overlooked. There is a lack of awareness. So it's really important that we raise the awareness of the implications of biofilm and how to control biofilm also. So I just want to start this this short presentation by referring to some of the global healthcare organizations and what they're saying about healthcare associated infections. So here, the World Health Organization, they published a fact sheet several years ago, and they stated that healthcare associated infections are the most frequent adverse event in healthcare worldwide, and that up to 10% of hospitalized patients will acquire at least one infection whilst they're in hospital. The most common healthcare associated infections are urinary tract infections and also surgical site infections. And if you look at the US alone, the cost of these two infections to the US healthcare on an annual basis is around $4 billion. So it's huge. And in intensive care units, approximately 30% of patients will acquire at least one healthcare associated infection. And the UK Department of Health, back in 2014 now, they reported that drug-resistant or antibiotic-resistant infections, as we know, they're escalating continually. They have been for the last 50 years now, but these could cost the global economy up to $100 trillion by the year 2050. So the magnitude of this problem is significant. This is a chart that was taken from a publication from Zimlichman and co-workers published in 2013 now, where they looked at the implications of the top 5 hospital-acquired infections in the US and what was the cost to US healthcare. So if we look at the left-hand side of this particular chart, we can see these 5 key hospital-acquired infections. So there's central line associated bloodstream infections, there's ventilator associated pneumonia, surgical site infections, Clostridium difficile infections. This is quite a special one because it refers to one particular organism that spreads significantly within the hospital environment. So controlling this one organism is extremely important to reducing infections. And then finally, catheter-associated urinary tract infections. And on the y-axis here, you can see the approximate cost per case, per patient of treating these particular cases. And if we look as an example at surgical site infections, so the treatment, if a surgical site becomes infected, then the cost associated with that treatment is close to $21,000. But we also know that in arthroplasty, so if it's knee replacements or hip replacements, and those joints become infected and they need replacing, then that cost rises to around $100,000 per patient. So again, cleanliness in that hospital environment is absolutely critical. And then we will look at the pie chart on the right-hand side of this chart here. This is just indicating the percentage share of the costs, and you can see again, just as an example, Clostridium difficile infections costing US healthcare around $1.5 billion annually. So considering these 5 types of infections collectively, costing the US global healthcare just under $10 billion every year. Huge problem. Another reference here, this is relating to healthcare associated infections in the National Health Service in England. This is a very recent paper that was published towards the end of last year, 2020, in the British Medical Journal. Julian Guest, the lead author, is one of the world's leading health economists. And what he did was to investigate the data for period 2016 to 17. And from this study, they estimated that there are around 834,000 healthcare associated infections in this period, which cost the NHS around £2.7 billion during that time. And this accounted for around 28,500 patient deaths and 7.1 million occupied hospital bed days. And this is equivalent to around 21% of the annual number of all bed days across the National Health Service hospitals in England. So again, a huge, huge problem. So in this particular paper, there was a call for increased awareness of the impact of healthcare associated infections to patients, to the NHS, and to society as a whole. Education regarding the severity and the importance of hospital associated infections is essential. They commented on strict adherence to infection control practices and guidelines. And also they proposed further investigation into potential technologies which support infection control procedures to combat healthcare associated infections. So this is where measures such as infection control, the use of appropriate disinfectants becomes quite significant in curbing the rates of hospital associated infections. And then finally, again in the US, the US Centers for Disease Control and Prevention, in 2013, for the first time, they started to categorize antibiotic resistant bacteria in terms of threat levels. And they identified certain organisms, two in particular, Clostridium difficile, that I've already spoken about, and carbapenemase resistant Enterobacter. And they reported these organisms as being an urgent threat level. So these bacteria are immediate public health threats that require urgent and aggressive action. And then other serious threats, multi-drug resistant Acinetobacter, antibiotic resistant organisms, Pseudomonas, and also methicillin resistant Staphylococcus aureus. So I think these slides collectively indicate the globality and the huge impact that hospital associated infections have on both patients and healthcare systems alike. And this all now relates to antimicrobial stewardship. I guess you've all heard of antimicrobial stewardships. They're now global, they exist around the world. And there are many definitions, but I've just included one in this particular slide from a publication back in 2017 now. But the definition of antimicrobial stewardship here is the responsible use of antimicrobials by healthcare professionals, and more specifically, to selection of the most appropriate antibiotic, the duration, the dose, and route of administration for a given patient with a demonstrated or suspected infection. So antimicrobial stewardship largely relates to antibiotics. It relates to preventing the misuse and promoting the responsible use of antibiotics, because we know that antibiotics are grossly overused globally. They have for many years been used in animal feeds. This has now largely been banned. But for example, in chronic non-healing wounds, antibiotics are grossly overused and misused. Often they don't have any effect, and they're used inappropriately. So antimicrobial stewardship is all about preventing misuse of antibiotics and promoting the responsible use of antibiotics. But what about the implications of biofilm? I indicated at the start of this presentation that I'd be talking more about biofilm. Now, in current antimicrobial stewardship initiatives, biofilm it's not seen, it's omitted, it's overlooked. And for me, this is something that is extremely important, and we need to raise awareness of this. Now, if we consider biofilm together with antibiotic resistance and antimicrobial stewardship, this particular paper here is one of my publications, my last publication actually, in September of 2020. But you can see from the title here, biofilm exacerbates antibiotic resistance, meaning it increases antibiotic resistance. And is this a current oversight in antimicrobial stewardship? I'm sure it is an oversight, and I'll explain why in the following slides. But it really is important. Another publication of mine from 2018, again, looking at the relationships between antibiotic resistance and biofilm tolerance and how these play a major part in chronic infections. So what is biofilm? Well, if we look at this particular image here, we can see bacterial cells. Now, these are rod-shaped. We would call them bacilli or rod-shaped bacteria. You can see there are lots of these hairy-like appendages around the cells, and these long ones here, these fimbriae, help the bacteria to move about in a liquid environment. Now, these cells we would call planktonic cells, a bit like plankton in the sea. planktonic cells, free living cells. So these could be, for example, Pseudomonas, bacteria that are actively living in a planktonic state. But bacteria, all types of bacteria, don't like to live in this planktonic state. They much prefer to attach to a surface. Could be any surface, and I'll come on to talk about that in a minute. But here in this second image, we can see how bacteria now, these rod-like bacteria, are attaching to a surface. They're increasing in numbers, but you can see the sheen here. It's looking quite mucoid. And this is the biofilm that these bacteria are producing. It's their protective environment. It's a slimy matrix that they produce around themselves. Once they've attached to a surface, they secrete this matrix around themselves that acts as their fortress. It protects them from the outside world. And if we look at this final image here, this is a scanning electron micrograph of similar types of organisms. You can see the bacilli, the rod-shaped bacteria here. And this is transitioning from planktonic cells to biofilm cells. And you can see if we allow these cells to grow on a surface, this is what they would look like after about 24 hours, maybe 48 hours, depending on the types of bacteria. But you can see the outline of the bacterial cells here, but they're now embedded within this thick, slimy matrix that they've secreted around themselves. And this is biofilm. So whereas these planktonic cells are highly susceptible to antimicrobial agents, then the biofilm cells are highly tolerant to antimicrobial agents. It's much more difficult for antibiotics, for antiseptics, for disinfectants to work against biofilm bacteria because the bacteria are protected within this self-produced matrix. So again, what is biofilm? Just to explain it in a bit more detail, aggregates or collections of microorganisms, could be bacteria, could be yeasts, that attach to a surface. The surface may be a viable tissue surface. It could be the lining of the bladder, as an example. It could be a non-viable surface. It could be a mattress in a hospital. It could be bed rails. It could be a door handle. These aggregates of microorganisms become embedded within this self-produced extracellular polymeric substance, otherwise known as EPS. An EPS essentially comprises water, so that's the bulk of it, water, and polysaccharides or sugars, which give biofilm its very slimy appearance. And there are other components of biofilm as well, but largely water and sugars that provides protection from environmental hostility. So protection from heat, from desiccation, from immune cells, from antibiotics, antiseptics, disinfectants. So the term biofilm is relatively new. It was actually only introduced into healthcare around 1985, but the life form is billions of years old. Bacteria were the first organisms to arise on Earth around 4 billion years ago. The Earth was a very hostile environment at that time, and biofilm, this protective matrix around bacteria, evolved at the same time to actually protect bacteria in very hostile environmental conditions. And here you can see a cartoon image of what a biofilm might look like. So this could be a tissue surface, it could be the bladder, it could be a wound surface, it could be skin. And here you've got what we call the planktonic cells. So these are the cells that generally cause infection. These are the actively dividing cells, and they will invade tissue. But many of the bacteria exist in this form, in these biofilm bubbles, where they're protected. So if a patient gets an infection, administer antibiotics, and the antibiotics deal with the active infection, the invading organisms, it doesn't touch, the antibiotic doesn't touch these biofilm cells. So the infection might resolve by killing the active invading cells, but the biofilm remains. And so more bacteria will be shed from the biofilm to cause another infection. So this is a very typical characteristic of biofilm-related infections. And biofilm is ubiquitous. It exists everywhere in nature. So we're all familiar with biofilm, whether we have a slimy shower head, the slime on rocks in an alpine stream. If you don't clean the toilet, apologies for this, but if the toilet isn't clean for a few days and you see all that scum, that is biofilm. A blocked drain under the sink, all this gunk here is biofilm. And you can't remove that simply by pouring bleach, sodium hypochlorite down the drain. You've got to physically remove that as well. So we're familiar with biofilm. And one of the leading experts in the field of biofilm research, a chap called Bill Costerton, he reported that 99% of bacteria in nature exist as biofilm. As I said earlier, bacteria prefer to live in a biofilm state. But a very recent publication now from 2019 did a calculation of the biofilm biomass on Earth. And they reported that biofilm dominates all habitats on the Earth's surface, accounting for up to 80% of the approximate 1.2 times 10 to the power 30 bacterial cell population. So essentially, bacteria dominate the Earth. Vast numbers of bacteria in all habitats on Earth, and the majority of them live in biofilm form, protected by this slimy matrix. But biofilm also exists in disease, mainly chronic infections. So whether it be a chronic wound infection, biofilm is associated with this. Ear infections, otitis media. This is an endoscope down the ear. An otitis media is a biofilm infection. Dental plaque. If you don't brush your teeth for a few days or even a few hours, and your teeth feel a bit furry, scummy, this is biofilm on the surface of teeth. And catheters, urinary catheters, if they're left in place for many days, then this is a cross section. The lumen becomes blocked with biofilm, and this leads to increased prevalence of infection, urinary tract infections. And the National Institute of Health in the US, back in 2002 now, they reported that biofilm accounts for greater than 80% of all the microbial infections that we may acquire. So again, indicating the prevalence and importance of biofilm. So how does biofilm develop? Well, if we look on the left-hand side of this particular image, we can see this is an electron microscope slide of planktonic bacteria, the rod-shaped bacteria that I referred to earlier. These individual cells we would call planktonic cells, and they will attach to a surface. But they need to adapt very quickly, and they adapt by starting to secrete this slimy biofilm matrix around themselves. And over a period of hours, this biofilm will grow to maturity. And depending on the types of bacteria, maturity may occur within 24 to 48 hours. So we're starting off with something that's microscopic, we can't see with our naked eye, but within 24 to 48 hours, we have this thick slime that we can likely see with the naked eye. And what happens with mature biofilm is that cells within the biofilm are shed into the environment to seed another surface. So it's essentially the first type of flowering plant where a seed grows, a flower forms, the flower sheds seeds, and the seeds grow again. And this is the same process with biofilm. So these are the susceptible cells that I referred to earlier, and these are the really hard intolerant cells that antibiotics, antiseptics, disinfectants find it very difficult to work against. So there is very much a life cycle to the evolution and growth of biofilm over time. So why is biofilm so important in healthcare? Well, it's tenacious. It's very difficult to remove. It sticks to a surface, and it's very difficult to remove by the physical means or by antimicrobial means. And this in healthcare can lead to recurrent infections. And again, as I referred to earlier in this particular cartoon, antibiotics will deal with the planktonic cells, but not with the biofilm cells. So the biofilm will remain. It's the root of the problem. So an infection resolves, but then more bacteria are shed from the biofilm to start to infect more tissue, and the infection comes back again. So recurrent infections, persistent infections, poor response to antibiotics and antiseptics are very typical characteristics of biofilm. Biofilm causes chronic infections, as I've referred to earlier. And biofilm, very, very importantly, encourages the spread of antibiotic resistance. And this particular extract here is from one of my papers from last year. The horizontal spread of antibiotic resistance genes and virulence factors and conjugation between cells within biofilm has been reported as being 700 times more efficient than among free living planktonic bacterial cells. So when bacteria exist in this biofilm form, they can much more easily exchange genetic material. So antibiotic resistant genes, antibiotic resistant genetic material can exchange much more readily from one organism to another. So this is the reason why biofilm is so important. It actually exacerbates, it makes antibiotic resistance even worse because it allows antibiotic resistance to spread amongst bacteria. So dealing with biofilm is absolutely critical. It doesn't just relate to humans, it relates you know, in the veterinary field as well. There's a book here that has been written on biofilm and veterinary medicine. I know all of these authors. Derek Knottenbelt was a very eminent veterinarian. He was one of the world's leading experts on equine veterinary care. And I've worked with these particular authors over the years, but biofilm doesn't just relate in healthcare. It doesn't just relate to human healthcare. It relates to animal healthcare as well. So looking at in a bit more detail at biofilm in healthcare settings, we can refer to wet biofilm. So wet biofilm, that will be associated with the likes of toilets and sinks and drains, even vases of flowers. So vases of flowers in the hospital environment, all that scum that forms after a few days is biofilm. So it is a precursor to infection. Vases of flowers even in the hospital environment is not good hygiene practice. But then there's something that's known as dry biofilm. This is where biofilm can even exist on clothing, on bed linen, keyboards, furniture, essentially everywhere. And one particular reference here from 2015, biofilm containing multi-drug resistant or antibiotic resistant organisms was shown to persist for up to 12 months on equipment and furnishings in an intensive care unit, despite prior terminal cleansing involving detergent and bleach. So despite good hygiene and infection control procedures, biofilm remain there. So when we're dealing with biofilm, we need to use tools that we know are going to be effective against biofilm. And I'll come on to talk about that later. So both wet and dry biofilms carry antibiotic resistant bacteria and increase the spread of antibiotic resistance. So from an antimicrobial stewardship perspective, we've got to do our part in preventing this. So again, the right infection control is absolutely critical. So how is biofilm managed? I'll just give two examples here. This is in oral hygiene. So this is what we do daily. To essentially, we're trying to control biofilm growing on our teeth with multiple strategies. So you can see the surface of a tooth here. This is dental plaque or biofilm. It actually looks worse than it is. It's been stained with a dye. But if we don't deal with this biofilm, then it can lead to infection. It can lead to gingivitis, which can ultimately lead to infection and abscesses requiring antibiotics, tooth decay, and ultimately tooth loss. So we want to prevent that on a daily basis. And how do we do that? We use essentially a protocol of care, oral hygiene. We use a toothbrush to physically help to remove that biofilm. We use fluoride toothpaste to help to clean. We might also use dental floss, again, to physically remove that biofilm. And ultimately, we'll use an antimicrobial mouthwash to, again, help to kill the biofilm bacteria that have been disrupted by the toothbrush. So it's that protocol of care that maintains good oral hygiene on a daily basis. And if we look similarly, wound hygiene, wounds very readily become contaminated with microorganisms that form biofilm. And biofilm is a major problem in wound care. So, you know, from a superficially infected wound, we want to prevent that from becoming more serious, from developing into an invasive infection, leading to necrosis or death of tissue, which ultimately leads to amputation. So again, it's a protocol of care required to deal with biofilm in these wounds, with debridement, essentially scraping that biofilm away from the wound, using cleansing agents, antimicrobial cleansers. One that is commonly used in wound care today, LifeClean, is another very, very effective antimicrobial solution that may be effective in this area. And then using antimicrobial dressings as well. So again, it's this protocol of care that's required to deal with biofilm and prevent it from becoming a problem. So how do we combat biofilm? Well, we know that biofilm is highly tolerant to antibiotics, to antiseptics, and also to disinfectants. So what we need to do, and if we look at these images again here, ideally we want to break down this biofilm in some way and convert the biofilm bacteria into planktonic bacteria. These cells are far more susceptible to antiseptics and disinfectants. So we can somehow break down that biofilm, release the organisms into a planktonic form. Then this is going to be a far more effective strategy to dealing with bacteria and infection in the hospital environment. Just moving on to talk about bacterial spores. Earlier, I referred to Clostridioides or Clostridium difficile, and I indicated in that US publication that this one bacterium alone costs US healthcare about $1.5 billion every year. This is an organism that spreads like wildfire within a hospital environment because it's very clever in that it can produce spores that survive the environment. So in this particular micrograph here, we can see these are Clostridium bacterial cells, and the light patches here are the spores that are forming. So what happens is the vegetative or growing cells will die, but these spores will be shed into the environment. So Clostridium is carried in the gut. Several of us on this call now may have Clostridium difficile in our gut. And while we're healthy, it's not a problem. But in patients, in elderly patients, those that are immunocompromised, then Clostridium difficile becomes a major problem, and it kills many elderly people through Clostridium difficile infection. So what happens is these spores are excreted into the environment, and they're not readily killed, whereas vegetative or actively growing bacteria would not survive in the environment. Spores will survive in the environment, and you can see in more detail here, this spore, this blue area, the growing bacterial cell will just die, but the spore will remain alive. And if we look at the under very high powered microscopy, the spore has got a very hardened and tough protein coat. The living cell is in the middle, and this is a very tough protein coat that protects the bacterium in the hospital environment. And this spore will only germinate again once it's in a favorable environment. So if Clostridium difficile spore is picked up on the hand to mouth, the spore is ingested, then it will germinate again once it gets into the intestine. And in elderly patients, in immunocompromised patients, this can very readily lead to Clostridium difficile infection and death. And as I reported earlier, Clostridium difficile infections account for approximately 5.5% of all infections within the NHS, the National Health Service in England. So this one particular organism is a major problem, and being able to kill these spores, make them non-viable, is really important. This particular inverted pyramid essentially refers to the susceptibility of different types of organisms, the tolerance, the resistance of these particular organisms. So as you can see, we're going from susceptible organisms that are highly susceptible to antimicrobial agents to those that are highly resistant to antimicrobial agents. So the most susceptible would be some of the envelope viruses, the likes of hepatitis B virus, HIV virus, cytomegalovirus. These are all envelope viruses that are very easily killed. Then you've got your vegetative, your actively growing or planktonic bacteria, then fungi, then your non-envelope viruses. So these are viruses that have a thicker protein capsid around the cells that make them more difficult to kill. Then a certain type of bacteria called Mycobacteria, Mycobacterium tuberculosis, you might be familiar with. Mycobacteria have a very thick lipid or fatty cell wall, making them very difficult to kill. And then virtually at the tip of the pyramid here, we've got bacterial spores. These are some of the most difficult. I referred to Clostridium difficile in the previous slide. These are the most difficult to treat. And normally spores are killed by sterilization processes, maybe moist heat sterilization or ethylene oxide sterilization. But there is some indication now that some disinfectant solutions might be effective against bacterial spores. Of course, biofilm is not considered here. We need to include biofilm here as well, because we know that biofilm renders bacteria very tolerant to antimicrobial agents. So just to give a few definitions on antimicrobial agents, because they can be misused. And the term antimicrobial agent is an umbrella term. It's a broad term that's used to describe an agent that's capable of inhibiting or killing microorganisms. So these can be bacteria, they can be yeasts, fungi, viruses. So there are different types of antimicrobial agent. Antibiotics is one type of antimicrobial agent. Antibiotics are generally naturally occurring or synthetic organic substances which inhibit or destroy selective bacteria or other microorganisms. So whereas antibiotics are used to treat quite significant and severe infections, they've got a very narrow spectrum activity. They can't kill a broad spectrum of organisms. Antiseptics, on the other hand, are chemical agents that can inhibit or kill a broad spectrum of microorganisms, generally on the skin. So antiseptics generally are used in hand washes. They can be used on mucous membranes as well, such as wounds. And then you have disinfectants. These, like antiseptics, are chemical agents that can kill a broad spectrum of microorganisms. They're more potent than antiseptics. And because they're more potent, they tend to be more toxic. So they're used on hard surfaces or inanimate, non-viable surfaces rather than on living surfaces. Ideally, disinfectants will be able to kill spore-forming bacteria as well. So if we focus on disinfectants in a bit more detail, disinfectants can be are categorized into high level, intermediate level, and low level disinfectants. Definitions here, I've included some of the references at the bottom of this slide, but some of the definitions of a high level disinfectant is a chemical agent that can destroy all microorganisms except for high numbers of bacterial spores. So some of these disinfectants that are reported here: glutaraldehyde, hydrogen peroxide at quite a high percentage concentration, hypochlorite at quite a high parts per million composition, hypochlorous acid. I think the other point to make here is that chlorine dioxide could possibly be categorized as a high-level disinfectant. LiveClean have recently generated a significant amount of data demonstrating the excellent sporicidal activity of the LiveClean chlorine dioxide disinfectant. So although it's not listed as a high-level disinfectant right now, hopefully in the not too distant future it can be recognized as such. So with high-level disinfectants, they're used essentially on devices that are used in close contact with the body, so endoscopes and bronchoscopes as an example. And then you've got your intermediate level disinfectants that destroy the actively growing or the planktonic vegetative bacteria, mycobacteria as well, most viruses, but not bacterial spores. So these would be used on non-critical items contaminated with blood, perhaps blood pressure cuffs. And you can see some of the examples of some of the disinfectants that are classed as intermediate level. And then low level disinfectants, which can destroy vegetative bacteria. So they act, again, the planktonic cells, some fungi, some viruses, but not mycobacteria and not spores. So again, these will be used on non-critical items such as bedside surfaces where there isn't any visible dirt or organic matter such as blood. So what I did in preparation of this presentation, I looked at some of the key requirements for cleaning and disinfection in healthcare facilities. And I found a report from 2019 by the US Centers for Disease Control and Prevention. And they provide a long list of the characteristics that they expect from a disinfectant, essentially. Now, there are a lot of words in this particular slide. I'm not going to go through them all, but you know, I've highlighted some of the key terms here. So they're looking for broad spectrum activity against a whole variety of microorganisms, including spore forming bacteria, that they're able to kill these microorganisms rather than prevent the growth. Preventing growth is not the same as killing. It may hold them in stasis, but what we want a disinfectant to do is to kill these cells, to be fast acting with a short contact time, and to provide some residual activity. So once the disinfectant is on a surface, it works over a period of time. Non-irritating to skin, ideally. It's not affected by environmental factors. So it's not affected by organic matter such as blood. It's compatible with materials, with cloths that are used as wipes and so forth. Obviously, being low cost and affordable is important. I think a very important one here, 13, does not cause environmental pollution. Some of the disinfectants that are currently widely used today do react with organic matter to produce some quite hazardous byproducts. So the environmental friendliness of disinfectants is really important. And stability as well, that the disinfectant can remain stable over a period of time. Now, what I did based on that list, I produced this chart. And you can see on this left-hand column here, these are, I don't expect you to read all the words here, but you can look at the colors. In the left-hand column here, I've used some of the requirements that the CDC had listed for ideal disinfectant properties, and then across the the top, in this top row, you can see some of the disinfectants, some of the commonly used disinfectants that are used today. In particular, in alcohol, I'm referring to ethanol here, the halogens, chlorine dioxide, chlorhexidine, hydrogen peroxide, and benzalkonium chloride. So the color coding here determines whether these particular disinfectants meet the CDC criteria or not. So green represents meeting the criteria, orange represents borderline, and the red represents not meeting the criteria. So you can see with alcohol, there are several aspects here that don't meet CDC requirements for an ideal disinfectant. Alcohols don't provide sustained activity over time. They lose their activity in the presence of organic matter. They're not effective against bacterial spores, limited activity against biofilm. In contrast, if you look at chlorine dioxide, and the blue numbers here represent references to provide evidence for the comments here, you can see that a lot of the characteristics are met by chlorine dioxide. So as well as some of the other oxidizing agents, the peroxygens and the likes of peracetic acid. So, you know, I think the likes of chlorine dioxide is something that is a disinfectant that's certainly worthy of more attention. So if we condense that and we look at the best-in-class disinfectant requirements, we need a disinfectant that rapidly kills bacterial spores and disrupts and rapidly kills biofilm bacteria as well, because as I've mentioned in this presentation, these are the two toughest types of microorganisms to deal with. And if we refer to that inverted pyramid again, we've got bacterial spores here. So if a disinfectant can deal with bacterial spores, and it can also deal with biofilm, as well as being non-toxic at efficacious concentrations, as well as being environmentally friendly, then this would represent the best-in-class disinfectant. So just to look very briefly about chlorine dioxide in more detail and compare it with chlorine or hypochlorite, regular or commonly used bleach. They're both oxidizing agents. They accept electrons chemically. From a chemical perspective, they accept electrons from other substances. But chlorine dioxide is a much better, more efficient electron acceptor compared to chlorine. So chlorine dioxide is about 2.5 times more effective than chlorine. And chlorine dioxide contains around 263% available chlorine, which is the killing component, compared to only 100% for chlorine. So hence, it's got a longer lasting antimicrobial effect, and the activity is less affected by organic matter. This is really an important point. Because chlorine dioxide has minimal reactivity with organic compounds, it allows greater capacity for disinfection and prevents the formation of environmentally hazardous byproducts. So again, a really important feature of chlorine dioxide. Chlorine dioxide doesn't react with most components within biofilm, and consequently it's able to penetrate biofilm and inactivate the bacteria much more effectively than chlorine. Chlorine is not able, it is reactive with biofilm components, and it doesn't penetrate biofilm as effectively. And another very important point about chlorine dioxide is that it works over a very broad pH range, whether it's on the acidic side or the alkaline side. Chlorine dioxide will remain effective as a disinfectant, whereas the likes of hypochlorite, sodium hypochlorite bleach, it will only work most effectively at acidic pH. briefly to talk about alcohol, ethanol that's used on skin and to disinfect surfaces. It is ineffective against bacterial spores. This is a major deficiency with alcohol, particularly when we're talking about Clostridium difficile that spreads in the hospital environment so rapidly. One reference here, looking at the effect of alcohol treatment on Staph aureus biofilms. It actually led to significant increases in biofilm levels after 24 hours of treatment. So this particular paper concluded that alcohols might be of limited usefulness for the eradication of preformed Staph aureus biofilms. So I think the jury's still out with respect to alcohol. As I mentioned earlier, if a disinfectant is safe, it's environmentally friendly, it can deal with spores, it can deal with biofilm, then that is an ideal choice of disinfectant. Alcohol doesn't meet those requirements. So just to look at the LifeClean chlorine dioxide disinfectant in a bit more detail. Credit to LifeClean here. They've performed a vast amount of testing of their chlorine dioxide products at independent laboratories across the world, certainly Europe, in the UK, in Sweden, in Germany. And I'm just taking some abstracts here from some of the data that have been generated. So in the presence of organic matter, so representing dirty conditions, LifeClean disinfectant at 400 parts per million showed a greater than 5 log. That's a greater than over 100,000 times reduction of C. difficile spores within two minutes. Now, that was testing that was performed at an independent laboratory in the UK. Incredibly good data. LifeClean disinfectant at 50 parts per million, a low level here, completely inactivated the SARS-CoV-2 virus, the coronavirus, COVID-19, whatever we wish to call it, within 2 minutes. Now, this was a virus that was actually isolated from a patient in March of last year. These viruses are not particularly tolerant or resistant, but again, at very low levels, 50 parts per million chlorine dioxide, it was effective against the SARS-CoV-2 virus. This testing was conducted in Sweden. And in extensive testing at independent test facilities, LifeClean disinfectant has been shown to be sporicidal, mycobactericidal, so it kills the really tough vegetative mycobacteria that can cause tuberculosis, leprosy as well, shown to be virucidal, fungicidal, and bactericidal. And I'm just indicating here some of the test houses, Dr. Brill in Germany, the MSL laboratory in the UK, and also Örebro University in Sweden, as well as the Swedish National Veterinary Institute as well. So some really promising data being generated by LifeClean on the efficacy of the chlorine dioxide disinfectant. Another point to make is that the LifeClean disinfectant does contain a surfactant or detergent, a soapy type component. Surfactants are very important in helping to disperse biofilm. So it may just be that surfactant within the LifeClean technology will facilitate surface cleansing and disruption of biofilm, as well as the killing component with chlorine dioxide. That is still to be tested, but it is promising. So really to bring this together, to summarize, the health and cost implications of global infection in healthcare facilities is absolutely huge. We've got to do the best we can to minimize these infections, the severity of these infections to patients, to healthcare. The cost are just huge. And we need to play our part. We know that antimicrobial resistance continues to escalate, and that antimicrobial stewardship is imperative. It's being actioned on a worldwide basis, there's no doubt about that, but it does focus on antibiotics and it doesn't focus on biofilm. And hopefully with this presentation, I've emphasized the importance of dealing with biofilm, because if we don't deal with biofilm, It enables a spread of antibiotic resistance. It enables a spread of infection across hospitals. We've got to deal with biofilm. And as I say, biofilm control in healthcare facilities is essential. And as I reported in my paper from last year, there's a necessity for effective anti-biofilm environmental cleaning and hand hygiene in infection control. So effective combination strategies that involves physical cleaning, best-in-class disinfectants are essential to minimize the spread of infection. And based on its multiple beneficial characteristics, chlorine dioxide has likely a very important role to play in hospital hygiene and infection control. So with that, that's the last slide from me. I hope that was of some help to you and put things into perspective. But if there are any questions, I'd be pleased to try to answer them. Thanks very much for your time.